this week on the Backtable Podcast.
Everybody doesn't walk into the tertiary referral center. People don't just come in tagged, I've got a desmoid, I'm just going to go straight to WashU, Mayo, or wherever. So I think, the more we can get a lot of these musculoskeletal interventions done by everybody and the broader adoption, that's kind of this old man's mission, is to get more and more people doing these, because they're horribly underserved. It's not just what we call the bone club, as to quote Sean Tutton. Let's get people feeling comfortable out there doing these.
Hello, everyone, and welcome to the Backtable MSK Podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on backtable.com. First, a brief message from our sponsor. RADPAD was developed by physicians for physicians, clinically proven radiation protection during cine and digital subtraction angiography. Don't bet your career or your health on anything less. Trust RADPAD radiation protection shields for all your fluoro-guided interventions. See radpad.com for more information and contact info@radpad.com for a free radiation evaluation and a no-brainer radiation protection cap. And don't forget to tell them that you heard about it on the Backtable Podcast. Now, back to the show. This is your host, Jacob Fleming. Today, I'm thrilled to be joined by a titan in spine and musculoskeletal radiology, Dr. Jack Jennings from Washington University in St. Louis. Dr. Jennings, welcome to the show.
Thanks, Jacob, for having me. Appreciate it.
It's a pleasure to have you, and really looking forward to talking about some really cool topics today. And before we do, I'd like to just introduce you to the audience. As I said, you're up at Mallinckrodt Institute of Radiology in St. Louis. And just correct me if there's anything I'm missing here, but you're Chief of Musculoskeletal Radiology, Director of Musculoskeletal and Spine Interventions and Procedures. You're more recently the President of the American Society of Spine Radiology and the PI for the Motion Center, which is something we're going to discuss. So one question I just need to ask on the front end is, do you ever sleep? And how do you manage to balance all these activities of leading a busy clinical section, performing complex procedures, and being academically prolific? How do you balance all that?
Yeah, and I guess the other thing you can mention, while we're combined, we have 9 kids. So I think that's the
wow.
That's the final. That's the other to balance that all out. We all are busy. Everybody stays busy, and I think we got plenty of time to sleep after this life. So I think, I just keep moving, and, I'm blessed to have a lot of good people around me for sure. None of this is done one person. That never is the case. So I think it's just keep moving, and, and I enjoy this world. I think it's made your job's much more fulfilling than just showing up to work every day. So that's my bias towards academia and doing stuff like this. It just gives that positive balance to the grind that we're all dealing with. But we're all busy.
That's great. I love that. And I should add for the audience that Dr. Jennings is in. This is a Sunday afternoon. Dr. Jennings is in on his day off to see some patients after procedures this weekend. So I think that's something that we can all really relate to, is a fundamental thing that keeps driving us forward is taking care of patients, and especially in this area, just a lot of really exciting ways to help patients that are coming out, and excited to talk about that today. So before we begin, I was wondering, could you tell us a little bit about the MSK section at Mallinckrodt? It's a very unique program for a variety of reasons. And can you tell us a little bit specifically about the Musculoskeletal Fellowship that you have at the program?
Sure. I'm Mallinckrodt inbred from the beginning. So Lou Galula, who was my mentor, who's passed on now, kind of started the interventional flavor of the MSK section at Mallinckrodt, and he did the first vertebroplasties in the Midwest. So Lou was kind of a pioneer when it came to pain injections and cement, and so MSK, we had diagnostic and intervention even the many years ago that I was a resident fellow. And then this evolved into interventional oncology. In fact, Lou, who was my mentor, we did the first cryoablation on him. I was a fellow, which that was quite stressful. He pushed us. He had metastatic thyroid cancer at the time, and we did 6 lesions. I'm embarrassed to say it took us 12 hours, but nobody had ever done cryo. This is in the days of, I called up Matt Kolstrom and Afshin Ganji and like, these are the lesions. Because nobody was doing it back then.
Right.
So anyway, that kind of started the whole MSK interventional oncology, which now here today, that's a big part of the fellowship. We have 6 fellows, and there's a diagnostic portion. There's sports, we do the Blues, we did the Rams, but that's a whole sore topic. Cardinals, we kind of get, you get secondhand reviewing of the imaging because Cardinals are all private practice orthopedists, not university, and then the local university. So kids, we have 6 fellows, they get diagnostic, but we're heavy interventional. We have 2 places where we're full-time every day running rooms. And then we have a 3rd place where a couple of days a week we do interventions. So it's unique in the sense it's super heavy on interventional oncology and cancer stuff. We do pain injections, we do a lot of biopsies, but there's a wide breadth and depth of the diagnostic.
Yeah, it just sounds like a really unique experience for the fellows, and it's one of the few musculoskeletal fellowships that really has a focus on spine procedures as well. So it just sounds like a great experience, and along with getting all the diagnostic as well. And today, one of the things we wanted to focus on was the topic of desmoids. And this is a unique topic, even within the fairly niche world of MSK interventional oncology. And so you are a widely recognized expert in this area, published a lot and have developed this practice. And I just like to know what is it about desmoids that makes them unique, and how did you develop an interest and expertise in this area?
Yeah, so desmoids, they're under the bill of sarcoma. So the people who take care of them are the medical oncologists who do sarcomas. And while, the other term is aggressive fibromatosis, but, while they're benign, they act horribly ornery and can act, malignant. They don't metastasize, but they're very locally aggressive, infiltrating fibrous tumors that can be hugely morbid and actually end up taking, somebody falls terminal and it dies from them. So, back probably now, it's been a decade ago, systemic therapy, sorafenib became the big thing that was going to take care of all these. Well, it hasn't. Then we've evolved into liposomal doxycycline. So it's and then some immunotherapy, and surgical resection is the definitive treatment. However, they're so locally infiltrative that to get margins, our orthopedic oncologists and surgical oncologists it's very challenging. So I think at the end of the day, where we've come now is realize it's such a multidisciplinary treatment of these. And it's, so your second part of your question, at WashU, MSK runs the sarcoma tumor board. Brian Van Tine is the oncologist who started this over a decade ago, and we started it with him. So that's kind of how we got our first foot in the door, was just being involved with the sarcoma tumor board. But I think once that sorafenib trial proved that it wasn't kind of the holy grail and the end all be all, more and more discussion. So prior to that, we did them, obviously the extra abdominal ones, and we can talk about that. We treated them. And then once sorafenib came, our numbers went down because everybody went to trial, and then people failed trial or they didn't tolerate sorafenib, and then it's definitely picked up. But I think how we got them is like how we got everything, being available and mentioning, hey, ablation is a good form of local therapy if this isn't a surgical candidate. And well, that was a long answer to your question, but it kind of all evolved based on being involved in sarcomas and treating sarcomas. And then this really became a center that a lot of desmoids were sent to.
Thank you for answering that. It answers a lot of the questions that I had. And as you mentioned, the nature of desmoids is particularly challenging because it doesn't metastasize, but they can behave very aggressively. And certainly, ablation is not really a one size fits all approach, but it's definitely been shown that for a variety of the reasons, difficulty with surgical local control, it can be a really excellent option for some patients. And so, could you tell us a little bit about what are cases in which ablation is a good option, and why is cryoablation typically the preferred modality? Are there other situations where you'd use a different sort of ablation modality?
Yeah. So, the first question is the ideal lesion. Well, the ideal lesion is always with desmoids. You don't typically get because those get resected. I feel like there's, the slam dunks, which I would want the same for myself. I mean, if they feel like they can get margins, say it's in the, there was a case of a deltoid lesion this young girl had, and it went to surgery. We ended up seeing it because it had a recurrence, but I would agree with the initial presentation. Take this out. They took out part of the deltoid, the infraspinatus, and they, from imaging, look like good margins. And so those are I would say the slam dunk lesions are typically surgical resection. The ideal lesions, I prefer knowing that are, those that are not involving nerves, those are not involving bowel. It loves the anterior abdominal wall. And I would caveat, I think all the listeners know we're not talking intra-abdominal ones. Those are an
Hmm.
absolute nightmare. Those, nobody, people don't operate unless it's, somebody's got a bowel obstruction, they have to, because those go hog wild if you touch them, even breathe on them, they go crazy. So we're talking about extra-abdominal desmoids and those in the extremities. But to me, the ones that I feel much better about are those that are away from any nerves, bowel, or things that you're worried about getting in trouble with that require a lot of added extra technique, thermal protective techniques and those kind. The second part of your question was why cryo? I think cryo is the perfect ablation modality for this for many reasons. One, you can see the low attenuation ice ball. Two, you can sculpt. And, desmoids don't come in these nice geometric prepackaged fashion. They're so non-geometric. So cryo is great for that because you can create ablation zones and sculpt them. You can see your margins typically. So that's nice because you want to get a good, at minimum, you want to treat these like you're doing cancer for local tumor control. So meaning you want to get a good 10 millimeter plus margin on these. And cryo, when you are near structures, nerves are much more forgiving if you do have a thermal injury. So I think that's another thing. And we can talk about thermal protective techniques, but so those are kind of the ideal lesions and not big, but I feel like they always come to you when they're big.
Sure. Yeah, I think that's probably a situation that's very familiar to many interventional radiologists. We're not frequently seeing the ideal lesions because we're the person to handle it because it's challenging and it's not really amenable to either medical or surgical techniques. And yeah, I would like to hear a little bit more about the thermoprotective strategies that you mentioned.
Yeah, I think if I were to harp on and I get up on the pulpit on a few things is that, putting the needles down are not rocket science. I think staying out of trouble, whether it's desmoids or any form of, it's, you don't have to think as much about this stuff when you're long, renal, liver, but anytime you go outside of that, you're often in an area where you got to think about nerves, whether it's spinal cord, sciatic, other nerves, femoral nerve. I think so with thermoprotective techniques, we use carbon dioxide gas. So that is better than air, but air is, unless you're in Minnesota, air doesn't freeze. So it's carbon dioxide is super protective. And the problem with that is getting it sometimes in the distribution you want. And then we do hydrodissection. Occasionally we'll do balloons, to push things out of the way. I will tell you that, bowel is, which many people on this podcast know, bowel is super sensitive to ice. So be very careful. There are times when I do these anterior-abdominal wall ones, it looks like laparoscopy. There's so much CO2 in the abdomen. It's, it's wicked full of, it's just, you just keep doing it to keep the bowel away. So I think always think that's how you're going to keep out of trouble, because obviously that's the last thing you want to do, and protect those nerves. Nick Kurup, my good friend at Mayo, has a great radiographics article on all the kind of musculoskeletal related nerves and where they are, when to think about them when you're doing an ablation, musculoskeletal related. And, I tell him he should pay me for this because I promote that article more than it's a great article. So it
is. It's a great article, and I'd really recommend that one, especially because I always find it really interesting thinking about nerves in the context of ablations and most of the CT guided procedures that we do in musculoskeletal radiology, because most of the time the nerve is not really immediately apparent to you. You kind of have to know where it is. So it's one of those elements of interventional radiology where you're going based on your knowledge and seeing something that's not really visibly there. So it's a really interesting, unique challenge. But yeah, that article from Dr. Kurup is a great one. We'll definitely link that in the show notes. So
yeah,
you can use some of these techniques like hydro or gas dissection, sometimes even balloons, to move these critical structures out of the way. Do you have a specific system for the CO2, and kind of what's your approach? What sort of needle do you use to do this CT laparoscopy approach?
Yeah, so we have the CO2 canisters in the room, and we draw up by take I guess they're now 50 ml syringes, even though they're the same 60s that we had. They just now labeled them 50, which 60s and on number. I take those syringes, fill them up. When you're close to the ice ball, if you use a 22 gauge, it'll freeze over. So I use 18 gauge because it will freeze over and then you won't get anything out. So I just really kind of dissect away. And, when you're doing your scans, you keep an eye, because that bowel, we're using the example of an anterior wall, it'll just keep floating back up and getting in the area where you don't want it. So you're often putting a lot. Now, where Hydropneumo dissection will help you sometimes, because remember, hydro will freeze. It's whether you use contrast, whether you use saline, D5W, it's a fluid, it'll freeze. However, you can create this kind of pseudotumor, and then you can get locules of the CO2 to stay in there instead of kind of going all throughout the abdomen. So I think it's worth trying the combined just to keep stuff in the area. But when that doesn't work, then I just go all out CO2 and try to just keep it floating in there.
Sure. So you really have to think pretty dynamically in these cases, and pretty regularly checking on the status of your hydro or pneumo dissection. And just to be clear, CT is your workhorse for these cases, is that correct? And are you using any sort of ancillary additional imaging like ultrasound or needle guidance technologies?
Yeah, great question. So CT is the workhorse. If I'm close to the skin, which these love to grow, I do I do a combined CT ultrasound. So I have the ultrasound. I can see the ice ball growing, because you get the streak artifact from the needles. It's hard to tell when you're getting close to skin. So anything superficial, I will do combined ultrasound and CT. My good friend and colleague, Afshin Ganji at Strasbourg, he will do some of these MR guided, which, then it looks like a nice black ball, and you can see the ice growing and nicely. I haven't been able to convince people here that I need more of my body colleagues to want to do MR guided procedures, because how everything's finances these days, and for me to tie up an MR scanner. Now we're talking about in the new tower just having a procedural MR scanner, but MR is really nice. I think then there's no question you see that 0 degree ice ball, but not practical in a lot of our places. So day-to-day use, CT, close to skin, or things where I'm going to have a lot of the streak artifact I don't feel comfortable with, I use ultrasound and CT.
Awesome. And I was wondering, a lot of these cryo cases end up seeing some very impressive intraoperative pictures, just with just dizzying array of cryo probes. And I'm kind of wondering, what's sort of an average case? How many probes would you use? Do you have kind of a personal record for the number of cryo probes you've had to use for a case?
Yeah, I'm not, unlike my good friend Jay Morris at Mayo. I'm more embarrassed by it than yeah. So and your question is relevant. Desmoids, that and a Ewing sarcoma are the two cases that I can think of that I use the most. And there was a recent in the last 2 years a gluteal desmoid that we used 28 probes.
Wow.
Now I will tell you that I divide those into 2 sessions, and why this may be, if I'm tangential, just because I can do that, stop me. But, you get rhabdomyolysis, and you've got to be very careful with that. So you got to check CKs, you got to give them hydration. So I divided it into 2 sessions, one where I came anterior, one where I came posterior. But that was the cumulative amount. And sure enough, this patient's urine turned like Coke, and
Yeah. Oh,
CK
geez.
went up in the thousands and thousands. And, we hydrated, kidneys did fine, the creatinine stayed normal. But I would tell you, if you're getting more than 10, think about it. There was a lady with a paraspinal desmoid who was like, she was an OBGYN nurse that was losing her insurance. So she was on Cobra and going to lose her Cobra. So she's like, you got to do this all at once. That was like a 16, 18 prober, but I was not comfortable, meaning I did it, but sure. I mean, we of course admitted her and everything went fine. And this was like 5, 6 years ago. And that thing's almost shrunk into nothing, but it was all
Wow.
paraspinal, covered like 15 centimeters, cranial
Jeez.
caudal. But again, only people that like that is the rep, not me. I don't feel great about that. And it's a lot of probes, but it's on an individual basis. And she was young. So anyway, the typical case, you're probably in the 5 to 10-ish average for desmoids, because like I said, they're usually hit you when they're big.
Absolutely. And what a great pearl that you shared there about the clinical management for these. You really do need to be concerned for potential rhabdomyolysis. And so you mentioned, are these patients all getting admitted after the cryoablation? And typically, how long are they in-house?
Yeah, so those that I'm worried about, I'm taking out a lot of underlying muscle. And and second, they're horribly painful, right? When you do cryo, soft tissue lesions, in fact, Afshin's got a nice publication. You got to tell people they're going to hurt more than they ever present with. There's a huge inflammatory response. And I didn't mention, I also give IV Decadron. I'll give 10 milligrams on the table, 4 milligrams, a couple Q6 hours following, then they go home on a dose pack, because it's a wicked inflammatory response and people do not like you. So whenever I do the consultation, I tell you, you're going to hurt afterwards. Huge inflammatory response. So I admit them twofold, for that and for the rhabdomyolysis. So I can follow their creatinine, their CKs, and so that I can have that pain under control. So I probably admit more consistently desmoids than I do, the metastatic lesion tumors.
Mhm. And when is their postoperative pain typically peaking, and when do they start to see some relief?
Yeah, so it peaks within anywhere, 24, 48 hours. The worst is we used to say the worst is the thaw phase, but I don't believe that anymore. I feel like it's that 24, 48 hours, and I can never predict who's I would rather be wrong and they're pushing me to go home early. I kept them overnight versus, send them. This is Missouri, so we get people from long distances, other states. So, I'd rather I sleep better that night and hopefully
Sure.
they sleep better. So but to answer your question, I find it in the first 24, 48 hours, and we could get things cooled down and then they start doing better. But some of these are so big that it takes a while for sure.
Sure. Absolutely. And on that note, what's kind of the time course for the actual diminishment of the tumor after the ablation? Is that a process of weeks, months?
That's another thing that varies. I feel like some we see, I won't get imaging for 6 to 8 weeks, and that's kind of my MO for even cancer stuff or local tumor control. But, I feel like some they start melting away quickly, and then others, that I referenced that paraspinal one, it took a good 2 post images, and now you just see some scattered calcifications up and down the spine, and it's pretty much gone. But it took a while. So I'm not sure I'm good at predicting which ones start to decrease in size. And my colleagues, it's our section who reads them, the initial ones afterwards can look bigger because of the inflammatory response around. And your ablation zone's beyond that. I keep telling them that's not all tumor. That's, ablation zone extending beyond that. But, we all show the great cases where they diminish to nothing, but that's not always the case either.
Sure. Yeah. And you've talked about a few of the cases that you've done and had some success. And as you've discussed, these desmoids show up in such varied places and never really in a conducive place. So they can be pretty challenging. You've talked about this paraspinal one. And I was wondering, could you tell us about a few cases that were particularly challenging, and maybe you have some success stories to share about those, and maybe, because not all cases are resounding successes, could you talk about a more challenging one that was a bit more difficult to deal with afterwards?
Yeah, the ones that seem to like to grow in the cervical region and they'll grow along the nerve roots, they'll extend down into the brachial plexus. Those are the most frustrating and challenging from everybody's perspective. And we haven't talked about those. Our goal is complete the entire tumor. And, desmoids are one of those that we've seen, and people published on the abscopal effect, where you see other desmoids respond. And also, so abscopal effect meaning you get decrease in size of non-treated tumor elsewhere throughout the body. But also we've seen where you treat 80% of the lesion, well, that part you didn't treat, that also decreases in size. But we've also seen you treat 80% of the lesion, that other 20% goes absolutely wild, crazy. And there, so I had a cervical case. We felt like we could get 75% of the lesion, and we did, but, within 6 months, that thing took off like wildfire. Not the area we treated, but then it started heading north. So I think my recollection was involving the lower cervical spine. Well, it shot right up, all the way to C3. So, and that can happen. But again, that's not even beginning to be a surgical case. So, this poor guy didn't have other options. I find those in the extremities wicked challenging because it's hard to get away from nerves when you're in a forearm or the arm, typically. And, a lot of these are in younger patients. Not that it matters that you wouldn't feel badly in older patients, but last thing you want to do is make somebody weak when they're 16 years old or whatever. These people with the Gardner's or Turco, some of these FAP mutations that desmoids are involved with. So, those are challenging. I had a few of those, and fortunately did not take out the nerve, but, a lot of sphincter tightening and a lot of, we did motor and somatosensory evoked potentials. And I didn't mention that, and shame on me with the thermoprotection. I gave you all the active thermoprotective techniques, but passive thermoprotective techniques, we use motor and somatosensory evoked potentials, nerve stimulation. We put thermocouples, so we put a needle with a thermocouple right next to the nerves to measure the temperature there. So those challenging ones that are evolving right next to the nerve, with the active thermoprotective techniques, we've also do passive.
That's a great point. I'm glad you brought that up with the passive neuroprotection, and it makes me think of another question. Are these cases mostly being done under general anesthesia or sedation?
Yeah, so whenever I'm doing evoked potentials, they're all done under anesthesia. That's torture to fire off all these people
Sure.
look like Frankenstein. They've got needles from head to toe. When I feel like the lesions, I'm not going to have to do evoke potentials and it's decent size, I'll do conscious sedation. Cryo is the silent killer. I can take out a nerve and the patient be under conscious, even minimal to moderate sedation, and they won't go boo. You can do microwave or RF, and heat is very toxic. Nobody's going to sit there and let you just start cooking a nerve. But cryo, it's kind of like the boo-boo on your kid. You put some ice on there and it starts feeling better. Well, that's the same thing with nerves. So when I'm doing cryo, the sphincters are tight when you're around nerves because you need to do everything because you can take out a nerve for sure.
Yeah, really great, again, to be aware of that. It talked about, recognizing the nerves and the potential for injury. And it speaks to not just the procedural aspects, but the perioperative management and also discussion with the patient about informed consent. And you mentioned this a little bit earlier, kind of talking to patients about things that they can expect, knowing that the pain is going to get way worse at first. And could you just tell us about what's your informed consent process, your discussion with the patient like?
Yeah, I think you've got to address, what bad can happen. And it's always you feel like you're focused on that. And it's not, from a medical liability standpoint, as much as just informed consent. And I do feel like though, I will repeat it. So we do the consultation and we talk about it. We show images. We talk about this is where, say, the sciatic nerve is. This is a gluteal tumor that extends into the sciatic notch. That's that case that I was talking about, that 28 prober. So that's one thing. The day of, we readdress it again. And, we talk about the things we're going to do to protect it. Still could happen. I find it, radiation's used for desmoids, but not as much. I find it super important when somebody's had prior radiation therapy. Threshold for nerve thermal injuries, much, much lower. So I really overemphasize that when people have had prior radiation in the field. That doesn't apply. Surely desmoids can get radiation therapy, but that's not our go-to. So I think that is super important. I overemphasize that they're going to hurt more. I overemphasize why we're admitting them. We talk about the renal function if it's going to be a big, if somebody is already borderline, depending on what their creatinine clearance is. So we talk about all that, but being an old man and done this for a while, I realize that people just kind of, but I think it's important. And it's not for you to say when it happens, well, I told you so. That's not the point. The point is somebody hears it, you've got a family member there, but it's, I think it's important. I think it's good for also being in a training institution for the resident fellows to hear what can go wrong and what we're going to do to try to mitigate and preemptively strike.
Absolutely. Really agree with that. And I think it's important to emphasize these things to the patients. Again, nothing to do with, like you said, the medical legal aspect of it. But so, and these are very challenging cases for a lot of the reasons that you've discussed already. And just making sure the patient knows what can, even if it hopefully won't happen, is going to make the process smoother as opposed to, with a, nerve palsy or something like that. No one's ever going to be happy with a foot drop or something like that, but knowing that it's a possibility can probably make that a little bit easier to deal with when it does happen.
I agree.
And I'd like to talk a little bit more about how you built up this practice. Talked a little bit about it earlier, and so I understand these are discussed at the Sarcoma Tumor Board. And so this is mostly the medical oncologists and who else is involved. You mentioned radiation oncology doesn't have too much of a role, but can you tell us about the multidisciplinary nature and how these patients are discussed in the tumor board?
Yeah, so, we have, I feel like now so many tumor boards, but it's for the better care of the patient. So sarcoma, you have medical oncologists, radiation oncologists, surgical oncologists, and then interventionalists. And, with these desmoids, while yes, not a true sarcoma, they, for all intents and purposes, that's where they fall under inappropriately. So, I mean, they're from mesenchymal stem cells. So they're appropriately under NCC Guidelines, they're under sarcoma. So that makes sense. And as with all majority of our tumor boards, the first question is, can this be resected, right? That's it goes to the surgeons. Is this resectable? And that's where we have the conversation, and how good do they feel they can resect these? And I think more and more our surgeons are, these are just tough to see. I mean, they're tough to separate from adjacent soft tissue. So they're very challenging. They have these finger-like infiltrations, but that's the first dialogue. And then is, whatever trials, is this liposomal doxy? Is it whatever, whatever trials are going on here, that's another conversation. And then we're involved with, is this ablatable? You feel like you can get the majority of this. And so it's kind of a natural progression for the multidisciplinary treatment. But I would argue to everyone out there is, don't do anything in a vacuum. So once you build your practice, things will start coming to you directly. What I do is I bring the rest of the team involved. I think, it's just better medicine, and it gives you more street cred, and, with your colleagues, it's like you're not some cowboy off, and you're, and especially those who are on these, OBLs and stuff like that. Try to get your own little multidisciplinary team. It's more challenging. I get it. It's easier in the ivory towers, but I think you've got to do that. It's better medicine, and it's better for you. But that's kind of how we do it, and everybody chimes in. And at the end of the day, I think it's not always binary or black and white. It's very gray. Medicine is. But I think we all feel good about this was the pathway we all felt is the first way to go at this, and these are what we were going to do second if that fails.
Yeah, that's great. I really like the point that you made about emphasizing that to some of our interventionalists who are practicing in a different setting than academics, where the tumor board infrastructure is really kind of baked into the institution. And that was one thing I was wanting to discuss, because you obviously have a practice where people are coming from all over to seek your services and the services at Wash U for this very particular problem. But patients with desmoids are everywhere, certainly. And so I think it does speak to the need to, at least think about how can care best be organized for these patients. There's no question that multidisciplinary is the way to go. But I really loved what you emphasized, that it's academic, quote, ivory tower setting is not the only place where that can potentially succeed. But really, really great to keep in mind. I think for a variety of reasons, you've made the case that the procedure, while challenging, is not necessarily the most difficult part of the case, and having those other specialists to back you up and everyone to come to a plan on what's the right case. Because as we've discussed, these tumors, is like, there's not really a typical one. They all require a different, unique way of approaching it. And it sounds like that's really emphasized at WashU.
I agree, for sure.
And so, talking about the earlier days of these treatments, obviously there's a lot more great literature now, especially thanks to you and some of the other giants in musculoskeletal interventional radiology. How did you go about building this practice when the literature was a little more sparse? You mentioned that before sorafenib, there really wasn't too much, and so were the oncologists coming to you and saying, "Hey, we don't really have anything we can do. Can you do something?" Or was it more you saying, "Hey, we have these cryoablative techniques to try to meet this need that's not currently met by your treatment"? What was sort of the genesis of that, and how have things evolved over the years?
Yeah, it started out with, which I think is one of the biggest deficits we have, is education of the oncologists and the whole multidisciplinary team. With the desmoids, again, and the other thing that I get up on the pole about, availability, right? If you want to be in, the interventionalist today is not like the interventionalist of 20 years ago, and interventional oncology is definitely, it's a clinical specialty. You got to be available. And I think that availability opens up the doors for whatever program you want you want to start. We biopsy everything here. We biopsy these desmoids. So that really is if you're trying to open the door for, we're talking about desmoids, well, these are going to get biopsied. Nobody's going to treat something this day and age, 2022, without having tissue. So that right there opens up your opportunity to help educate people. And back when there wasn't, there's not great literature, but hey, it's in the NCC Guidelines. And so that's another opening thing we can talk about. But I never found, while oncology is so evidence-based and guideline-based, that was never the burden of proof. It was more about relationships and people trusting you're going to do something that you feel and that there's some evidence out there that this works. And I never felt like I had to. It's more with the third-party payers that I felt like I had to bring out all the evidence and slam them with that. But, I feel like it's about developing relationships and being available. And, that's how you build a practice. And then only the faces change. Is it desmoids? Is it spine? Is it, whatever, pain injections, whatever it is a lung. You want to get into lung ablation. I feel like once you become part of that team, it just requires you educating them of this can be done. And, and then they rely on you. I've never felt the burden of proof. I never had to come with them with literature and hit them up with that. And, it's more about just getting a few people that you met or know as your advocates, and then it kind of grows like wildfire.
Oh, that's a great point. I really like that. And we recently had Alan Sogg on the show from Duke, and he mentioned the NCCN guidelines that you just alluded to. It's a great point that a lot of the work has already been done, and some of these recommendations are baked into those guidelines. I think it makes it a little bit easier to approach and start making those partnerships with colleagues in oncology. I really like what you said, though, that's really the most important thing. It's not hitting them over the head with a trial or success rates or receiver operative curves and things like that. It's really coming to them, emphasizing how you can use your approach to provide a service that's filling a gap for these patients. And with desmoids, that gap is pretty obvious for all the reasons you discussed that make this a really challenging tumor to treat. And could you elaborate a little bit more on the NCCN guidelines and where does interventional radiology specifically show up in those for desmoids?
Yeah. So, if you go under, the sarcoma, if you go under that, there's a whole thing on desmoid tumors. And, in the treatment algorithm, ablation is in there. And, I'll put my little plug. I know you are talking with our SIO executive director, Jenna, so this is the plug for SIO, shameless plug, but Society of Interventional Oncology has had a lot to do with the NCCN guidelines and getting, we attacked desmoid, we attacked the adult cancer. When I say attack, provided them with updates and things to make them more relevant. And we've gone very far in the sarcoma realm, the adult cancer pain for ablation. Now I'm getting more global with ablation, but, and I think that's one of the things that we're very proud of at Society of Interventional Oncology is that making those headways in the NCCN guidelines. And I will put another little push for the NCCN guidelines. And, I'm not on the panel for this. We have people at WashU, you're only allowed one per institution on both of those, but there are certain third-party payers when you're doing a peer-to-peer that if you can give an NCCN guideline, they're instructed to approve it. I've sent the NCCN guidelines, and I probably shouldn't be saying this over there. It's probably some violation of, but I've given them the PDF for it because they don't have a link for it to show them that this is in the NCCN guidelines. So that's another little tidbit for people out there when they're trying to get these approved and they don't have that quite the relationship with the third-party payers for doing these in their little network is using the NCCN guidelines for whether it's sarcoma, for ablating of other bone lesions, adult cancer pain, these can be super helpful. And I'm not even sure, Jacob, I answered your question now that I say that.
Absolutely you did. That was excellent. And I'd like to show some appreciation for Society of Interventional Oncology. big fans of SIO over here at Back Table. And in particular, we're talking about musculoskeletal oncology. I've been really pleased to see how SIO has really focused on this subspecialty in the last few years, and really appreciate all the work that's going into that from all the physicians involved there, and then also the organizational structure. Just a lot of great stuff coming from SIO. And somewhat on that note, I would like to talk about a topic you alluded to a moment ago, probably the single most exhilarating topic we'll talk about today, which is the issue of the third-party payers. And I'd just like to know what are some experiences you've had dealing with insurance. I've heard that this is not an uncommon issue to run into snags here. And have you had? I'm assuming you've had situations where you've had to go to a peer-to-peer review. How do those typically go, and what are some strategies?
Yeah, that's a great question. So I tell you one thing that I do, a preemptive strike, and it's kind of the template in my consult notes, depending on what I'm treating, is I've got a line of where it's supported in the NCC Guidelines and the relevant literature. I put that at the end. So they've got a little bit, they got the papers, some more recent papers, the cryo Desmoid, the European big trial, phase 2 trial that my good friend and colleague Afshin Ganji was on, and some of the bigger papers, we're talking Desmoids now, but I do it for everything that I do that I know that, whether it's Blue, whether it's United Health, Cigna, that I know that they're going to be ornery on. And when you're old like me, you start realizing who's going to be ornery and who's not, and what verbiage, what verbiage you got to put in there. So you try to make it less grief. And, our nurse coordinators and extenders all know all that, the verbiage we use. But, I think really knowing the guidelines and working, you're the patient advocate. So I don't get ornery until I realize that the person I'm on with can't do anything and I'm going to have to go to a higher level. Then I get a little, ornery with the physician that I'm talking to. But I really like the preemptive strike, putting this stuff in there, addressing the NCC guidelines up front. I even give them the, I'll say SARC D2 or DSMM, Desmoid DSM-4. I'll give them the page where it's talking about, the algorithm of, for Desmoids we're talking about now, but I'll give them all that so that they can go to that. I think I haven't had to do this a lot in my career, but I have done it. These are painful for many people. And I sometimes will give that threat. This is the last ditch effort. All they got to do is come to the ER and we admit them, and then you really don't, then it's, we treat them. So that's rarely do you have to do that. I really think, and you establish a relationship over the years with them, and then you get less flack. But early on, Matt Kallstrom, again, I look at he and Afshin Ganji as my two major mentors. I got what Matt sent me his letter that he sent to Blue Cross Blue Shield of Minnesota for cryoablation of bone metastasis. So I basically used that. And, so I had people helping me. And like I said at the beginning, this is a team, right? Your stuff is done because of a team. And that team consists of people around the world and your colleagues from other universities. But yeah, Matt sent me that. I sent it to Blue. So then I started getting a relation with Blue. They use the same thing for United, blah, blah, blah. So I think preemptive strike is your best method to start up front. Put that information in there so then they don't have to try to avoid the peer-to-peer. It's not perfect, but at least you've given them all the information. When you're doing the peer-to-peer, you can reference. Say, well, this paper that I showed you, blah, blah, blah. That kind of stuff.
Yeah, that's a great approach, trying to be proactive with it. A little bit of time up front in your documentation can save a lot of headaches down the line. This is an unfortunate reality of the American healthcare system. We're exposed to even as medical students, and it's an unfortunate reality, but it's great. This is not a, sort of cowboy sort of thing of interventional radiologists just saying, hey, I'm going to freeze this thing to death because, why not? We have, as we've talked about, specific guidelines, we have criteria, and those are things that can be cited and make it so the patient can get the treatment that they hopefully need. I appreciate that you mentioned the aspect of if a patient has pain and we can't get it treated, the unfortunate reality of sometimes needing to come in through the emergency room to get these treated. It's a reality, and I think something that we have to be aware of, but hopefully that's not something that's frequently needed, and they can go through. Okay. Yeah. Being able to go through the process with the multidisciplinary tumor board and making sure that everyone's relatively happy, including the payers. It's a lot of boxes to check, but it's nice to hear that you have a bit of a system down for that.
Jacob, one more thing you reminded me. That's the other thing that I do put in the note. I put in the multidisciplinary discussion that happened. So I give, whether it's Mannheim sarcoma, the orthopedic oncologist, I put that all in there. This was discussed in a this patient's not a surgical candidate because blah, blah, blah. So because we're talking about desmoids, I really think I put that in there as well as a preemptive strike, that this was discussed with a group of people, that they'll see these names that paid for them to see, that sarcoma doc. They should know that these were physicians that are part of this patient's care. But I think that's another good point that you made me think of when you're talking about the multidisciplinary team. That is part of the preemptive strike as well.
That's a great point, really great point to emphasize. And I'd like to pivot a little bit. We've talked about a lot of really interesting aspects of desmoids and their treatment. Is there anything else you'd like to talk about desmoids?
I don't think so. I would push the people out there, especially, in the OBLs and, like I said, not at the tertiary referral centers, these show up. My wife's in private practice. She reads MR. She sees these. I mean, everybody doesn't walk into the tertiary referral center. People don't just come in tagged, I've got a desmoid, I'm just going to go straight to WashU, Mayo, or wherever. So I think, the more we can get, and now I'm going to, Jacob, go broader, a lot of these musculoskeletal interventions done by everybody, and the broader adoption, that's kind of this old man's mission, is to get more and more people doing these, because they're horribly underserved. And, I think now the SIO, this is the thing that we're realizing. We've got to get out to the community and it's not just what we call the bone club, as to quote Sean Tutton, people who, to doing this, people can do that. And we're seeing it, that's why we're getting more and more people, doing these, but we got to get more and more, it's such an unmet need. And, so I think my shameless push would be, let's get people feeling comfortable out there doing these. And all these names I've dropped to mention, people are all approachable, including myself. And, I think this is discussed at SIR, SIO, the meetings. Desmoids is a very hot topic. So please reach out to these individuals so we can, people can feel comfortable doing this. We're more than happy to help. And again, I think I got tangential on you, buddy. I probably didn't answer.
No, that was fantastic. I'm really glad you mentioned that, and I really love that perspective, and I really like that mission of spreading this treatment for patients. And you reminded me of one thing, the aspect that most of these patients showing up for the first time, their initial imaging is probably not going to be done at a tertiary quaternary care academic facility. So some poor, community practice radiologist is probably going to be the one, in a sense, diagnosing these for the first time. Can you give us just really quick kind of basics on the imaging features of desmoid tumors, so that most of our base audience is practicing interventional radiologists, and it may have been a little bit while since they've taken the core exam and seen some images of a desmoid. So what are kind of the imaging characteristics?
Yeah, I'm glad you focus on the imaging, because that's another thing I get in the pulpit with our body interventional kids about. You're a radiologist, so just because somebody else called something maybe wrong, right? Everybody's going to look at you as a radiologist. So desmoids, one of the classic features of them is their fibrous tissue, and that's dark on T1, dark on T2, and you see this kind of infiltrating mass heterogeneously enhancing, but that's kind of the classic. Now, where it gets confusing on imaging is when there's not as much of that hypointense T1 and T2 stuff, then you're questioning. Now, I will tell you from experience, I feel like you put a needle on this and I feel like I'm really good at, because they're dense fibers. They will bend a 14, 12 gauge needle trying to get into that because they're so rock hard. So
Wow.
I had one recently in a young girl who didn't have a lot of that T1, T2 hypointensity, that fibrous. It's black. But boy, when we got into, because I was afraid, oh gosh, is this a sarcoma? She was a 21-year-old girl, worked at a local pharmacy. But once I got in there, I'm like, yes, I felt, and again, it came back as a desmoid because, I mean,
Sure.
that's much better than her having a sarcoma, but
Right.
the imaging wasn't as straightforward. So I want to tell you that it's not always classic, but from a soft tissue sarcoma, so that's why they have to be biopsy. But when you see this dark T1 and T2, you can feel pretty comfortable this is probably going to be a desmoid. Then you say, well, what about all the fibrosarcomas? They can have some of that, but again, this is pretty classic for desmoids to have a lot of this dark T1, T2.
Oh, that's a great review. And I really love that you brought back up the point of biopsy. I think it emphasizes the unique role that radiologists play in this disease state, from the initial imaging diagnosis to the definitive tissue diagnosis. And as we've been talking about, the potentially definitive treatment. I think it just really speaks to why interventional radiologists should be really interested in this area. Obviously, I'm preaching to the choir on that. But I love that story about doing the biopsy, and you've done 1 million biopsies of these soft tissue masses at this point. And so you have the tactile sense to, when you get into something, you kind of feel, okay, that's not a sarc. That's a really interesting talent to have.
And please don't, this is not a, this has not been proven, but it is. You do feel,
Yeah.
There are a few things, just like with the melanoma, when your tissue's black, I feel pretty
Sure.
comfortable that pathology is not going to offer me anything new. But yes, no, it is reassuring, but the emphasis, and I know I interrupt you, but emphasis, biopsy, always biopsy. Our surgeons now, compared to 15 years ago, even like some hemangiomas, I like, this is really we want tissue. So I feel like that's the gold standard, and that gets you in the door as the interventionalist for sure.
Yeah, absolutely. You mentioned a great article, I believe, from Dr. Kurup earlier about the paths of the nerves and how that's important to the interventionalist. There's another great article that we'll try to link to that's about basically fundamentals of good MSK biopsy.
So that's Lou et al. Yes,
Lou,
correct.
yeah, that's a great paper, and we'll link to that. It's a little bit probably too deep to really dive into today, but having a very thoughtful approach for your needle trajectory and discussing this with the surgical oncologist really keys to basically having the best game plan in case something were to go wrong. And just thinking about that, one question I wanted to ask, part of what that's referring to is the potential for tumor seeding, which definitely exists with certain neoplasms. Is that something you see with desmoids?
No, and I'll be honest with you, we rarely see it. And we always do everything coaxial, so that helps. So really you're only going in once with that outer needle. But while it's real, it can happen. I think if you talk to people, the number of cases that it happens is super rare. I liked your point and can't emphasize enough. Talk to the surgeon. If this is something that's going to be a primary bone or primary soft tissue tumor, make sure you're good with what the pathway they want. More and more with neoadjuvant radiations, I feel like some of the newer ortho oncs and surgical oncs don't care as much. The old school guys and girls totally did.
Mm-hmm.
Whether it's a Smith-Peterson interval, deltopectoral interval, lateral in the lower extremity, all those. That's why the Lou paper is good. But to me, there's nothing better than confirming with the person that's going to resect this if it ends up being a primary. So, and again, that also gets you in good favor and good communication with potential referrers for these ablations.
Absolutely. Yeah. Once again, it just speaks to the importance of relationships when building these practices. And on that note, I would like to spend a moment discussing the motion study, which is a huge, extremely collaborative approach. You were the PI on this study, and also includes just the all-star team, including some of the names you've been discussing throughout the show and numerous others. So this was a study of cryoablation for palliation of painful bone metastases. Can you tell us about the motion study? When did it get started? What are the findings, and how does this impact clinical care?
Yeah, so boy, this was a study many years in inception. And, Matt Kolstrom did the 2013 cancer. That was a prospective cryoablation trial that took, he had the preliminary publication in, was it 2006 or 7? So it shows how hard it is to enroll these trials. The purpose was to, just solidify the palliative technique of painful of a single isolated bone lesion. The primary endpoint was 8 weeks, with a 95th confidence interval of less than -2, greater than -2. And, this trial then went out for 6 months and looked at pain, looked at morphine equivalent dose, so pain medication, looked at quality of life issues, looked at complications. It kind of covered everything. And, it showed significant pain reduction all the way out to the 6 months, significant pain. So nothing new, other than, it was another prospective trial to solidify that this is a palliative technique. The interesting thing about it was these lesions were big. If you look, I think it's over 75% were greater than 4 centimeters. These were not small lesions.
These are huge. Those are huge metastatic lesions.
Yeah, so probably not always ideal for a trial, but it's the reality, and we avoided lesions that were weight bearing because we didn't want to confound it with cement and all that. But, again, with the group of people that work with for over a decade, a great group of people. And I think it again just solidifies that if you look at all the bone ablation trials, soft tissue, they've all had significant pain reduction, even in the spine. So I feel like we've shown that. Now we're evolving into local tumor control and trying to do some prospective trials with that, for patients who are oligometastatic. So that's where we've evolved into. But yeah, it was a good trial. It just ended up being much bigger lesions than I would have anticipated for sure.
Yeah, it's a great trial. I'd really advise anyone in this area of musculoskeletal oncology interventions to definitely become very familiar with it and the paper, and really want to give our appreciation to you and the numerous other people who have made this happen. As you mentioned, just a lot of these things that we talk about is cryoablation improving pain. They almost seem self-evident to us, but to go through the proper infrastructure, clinical trials to really prove beyond a shadow of a doubt that what we do is valuable just takes immense and prolonged effort. I think really speaks to, we gave a shout out to SIO previously, and I'll reiterate that, SIR as well, and interventional radiologists just being part of these societies so we can really paper that up and get that data to show that what we do really does make a major impact for these patients, and who often have no other option in the case of both desmoids and painful osseous mets. So thanks again for all your work on that. And it's really something that our listeners should check out.
Well, thanks for having me. It's been great. I enjoy this. Is like I said, this is a great part of our job, and I love talking about this. So I really appreciate you having me. Very kind of you.
Absolutely. It's been a pleasure. I want to thank you so much for joining us, and really looking forward to a lot of our listeners getting to hear about this. And like you talked about earlier, I would really like to see this treatment, particularly for desmoids, become more prevalent. So I'm hopeful that a lot of our listeners will be very interested in this, and hopefully start to spread the gospel throughout the country and hopefully the world.
I agree.
Well, Dr. Jennings, again, I just want to thank you for your time. Is there anything else you'd like to discuss? Any final words before we end?
No, thank you. And like I said, listeners out there, always available, reach out. I'm easy to contact. Everybody has my cell phone or my email, so if I can help in any way, please do, and appreciate all your support at SIO and SIR. Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BacktableMSK on Instagram, Twitter, or LinkedIn. Backtable is produced and hosted by myself, Jacob Fleming, and co-hosts
Michael Barraza
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Junroy Kennebrew.
Thanks again, and see you next time.